Okay, still in primary assessment, now we're talking about breathing, which is paramount in a child, the ability to assess their breathing. Now, if you show up at a scene, it's best to try to get a respiratory rate or look at their breathing before you start poking on this kid, which means you show up to a scene and mom's still holding the child. Don't poke the child yet, stand back and try to get a respiratory rate before we lay hands on this kid. You're more likely to get a more accurate rate. They're not going to be agitated and start breathing fast or crying. When you're assessing the rate, try to get a count for at least 30 seconds. Know that a child's respiratory pattern will speed up and slow down naturally, so we really need to assess the rate over about 30 seconds. That'll give us a more accurate reading. Now, you have to know the norms, just like in anything else. So you have to kind of look at this chart here and know what's the normal respiratory rate for a particular age of the child. Now, any respiratory rate less than 10 or greater than 60 is a huge red flag. First, let's talk about fast respiratory rates. When we're talking about fast respiratory rates, it can be one of two things. It can either be a lung problem or it can be non-lung in origin. Let me give you an example. Let's say they're having an asthma attack. In an attempt to better oxygenate, they're going to breathe faster. If they have pneumonia, fluid in the lungs, they're going to breathe faster in an attempt to better oxygenate. So fast respiratory rates are usually compensatory in nature, but they may not always be from a lung problem. For example, let's say they're in DKA, diabetic ketoacidosis. They may have a fast respiratory rate because they're trying to blow off the acid. The lungs are fine. So we have to assess for and find the cause of this fast respiratory rate, which is usually compensatory in nature. Other causes, pain can cause a child to have a fast respiratory rate. Lungs are fine, the body's fine, he's just in pain. We need to treat that. He could just be anxious. I show up in my flight suit, I look like a cosmonaut, I'm scary to a kid. I'm probably scary to most people. They could just be anxious and breathing faster. So we're going to help calm them down. So we need to assess for, find the cause of this fast respiratory rate and treat that. But know that a fast respiratory rate is usually compensatory in nature. Okay, slow respiratory rates. A slow respiratory rate in a child is an ominous sign.
Anything slow in a kid is bad.
Slow respiratory rate, slow heart rate are ominous signs the child is pre-arrest. Usually when things are fast, we're compensating. Until they can no longer compensate, then things start to slow down. So we need to find the cause of this low respiratory rate and treat it quickly. For example, an overdose. Did the kid get into a drug that is a respiratory depressant? Older children, you may see this. Heroin is running rampant in America. We need to assess for an overdose. Number one, start breathing for the child. If they have a slow respiratory rate, we need to open that airway. We need to begin to bag, oxygenate, and ventilate that child. That's our priority. First, get their respiratory rate up while you're assessing for the underlying cause so you can treat that. Now, in assessing their breathing, after we've gone through their rate, we're going to look at the quality of their breathing, which means we're going to listen to lung sounds. So we have our stethoscope out, we're listening to this kid's chest. What are we listening for? Well, wheezing is one thing. Asthma in children has grown exponentially in America, and you're going to hear this high-pitched wheezing sound, and this is caused by constriction of the airways. Usually you'll hear it during exhalation. As the child breathes in, those airways open up. Airway pressure increases, the airways open up. As soon as the child starts to exhale, the pressure in the lung drops dramatically and those constricted airways squeeze down. So it's trying to squeeze air out of these constricted airways, and that's what creates the whistling sound. So if you have an asthmatic child and you're listening, inspiratory, you may hear expiratory wheezing. It's worse if you hear both inspiratory and expiratory wheezing. That means there's constriction of the airways during the inspiratory cycle when that airway should be opening up. Grunting, and you can hear this from across the room in a child. And children grunt by closing their glottic opening, usually during exhalation, in an attempt to keep the airways open. Think of it as auto peep. They're trying to auto peep, maintain this open airway, reverse the effects of atelectasis so the child can better oxygenate. And the result of that is the child is grunting. So we know if we hear grunting, they're self-peeping. They're trying to keep their airway open. They have respiratory distress. More assessment tools to see if this kid's in respiratory distress. You have to expose and look at the chest, and we're looking for retractions. Now, what causes retractions? Remember, when the child breathes in, the diaphragm drops down, creates a negative pressure, and they're trying to suck air in. If they have an obstruction in their airway, from edema, constriction, whatever, the air can't get in, but they're still creating negative pressure. So they start sucking in literally parts of the chest. You may see retractions underneath the collarbone, intercostal, in between the ribs, above or below the sternum. So we're looking for these signs of retraction, and what that tells us is the child is trying to take air in, but the air is not coming into them, but they're generating so much negative pressure that they're literally sucking the chest inside the body. Huge sign for respiratory distress. Next, another assessment tool on how well this child's oxygenating is the use of pulse oximetry. Now, a pulse oximeter really doesn't measure oxygenation. It measures bound hemoglobin. How much of that hemoglobin circulating through the body is bound up, and the machine will give us a percentage of that. Usually it's oxygen. However, know that with carbon monoxide has a greater affinity than oxygen to the hemoglobin. So you can have essentially a dead person from carbon monoxide poisoning, but their pulse ox reads 100% because the hemoglobin is 100% bound with CO instead of oxygen. Having said that, in most cases it's oxygen. That's what we're looking for. Now, concerning the pulse oximeter, it's not enough just to put the pulse ox on the child and get a reading. You have to put the pulse ox on the child, then verify that it's an accurate reading. How do we do that? One, the pulse oximeter itself. The two probes have to be opposite each other. There's an infrared wave that goes through the tissue that looks at the bound hemoglobin. So the two parts, the two physical parts of the pulse oximeter itself have to be opposing each other. You can run into a problem with this if you're using the kind of pulse oximeter that tapes onto the child. Let's say the child's finger is too small and we have one probe here but another probe over here. They're not opposite each other. You may not get an accurate reading. Now, another thing, remember this is a pulse oximeter. Remember pulse oximeter. On the pulse oximeter itself, it's going to give you a pulse reading. And that pulse reading should match the pulse you're taking from the patient or what you're seeing on your cardiac monitor. So, if your cardiac monitor says 100 beats per minute and your pulse oximeter says 60 and you have a low sat reading, it's probably not accurate. It's not verified. They don't match. Those numbers have to match. Also, if your machine has waveform pulse oximetry, you should be looking at a good arterial waveform. If it's flattened or disrupted or anything but a normal wave pattern, that reading may be inaccurate. So, the probe has to be opposite each other, the pulses have to match, and you should have a good waveform or bar reading on your pulse oximeter to verify that we have an accurate pulse oximeter reading. Now, if you're using your pulse oximeter, you verified it, the pulses match, you have a good waveform. If you're giving this child 100% oxygen, you're administering 100% FiO2 to this child, and their pulse oximetry is still coming under 90%, this child needs a more advanced airway. That's one great use for a pulse oximeter. Again, 100% FiO2 with a pulse ox less than 90, whatever you're doing is not working. You need to up the game, move to a more advanced airway so you can better oxygenate that child. Remember, the number one cause of cardiac arrest in a pediatric patient was respiratory in nature. So it is a constant reassessment of this pediatric patient's respiratory status. Evaluate, identify, and intervene. Constant reassessment of the pediatric airway can help keep that kid from arresting in the first place. So this has been just a quick review of the breathing assessment for the primary assessment in a pediatric patient. I'll see you in circulation coming up next.